Hello, my name's Dr. Roger Henderson and I'm a GP in southwest Scotland, and I also co-host the GP Notebook study groups. Welcome to this GP Notebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. Now, you can find us on all major podcast platforms, including Spotify, Apple Podcasts and Google Podcasts, so do please follow us to receive notifications about new episodes, and if you like what you hear and you tell us you do please consider leaving a review to help other listeners find us. You can also follow us on Twitter at GPnotebook for more information about new podcast episodes and study groups, and you can find me on there too at Roger the Doctor. Finally, you can visit GPnotebook.com for podcast episode show notes and to find out more about all our upcoming study group meetings. Now, in this podcast, I want to look at goitres. And one of the reasons I'd like to do that is that about 15% of the UK population will have a clinically detectable goitre or thyroid nodule during their lifetime. And so these numbers are significant. And fundamentally, a goitre simply refers to an enlarged thyroid gland. And the common causes we would normally see in the UK include thyroiditis, and typically Hashimoto's would be a good example of that, Graves' disease, a multinodular goitre, colloid nodules or cysts, follicular adenomas, and occasionally thyroid cancer. Now, globally, iodine deficiency is the most common cause of a goitre worldwide, but it is rare in the UK. It can happen, but it is rare compared to the other common causes that we typically see in our practices. Now, smoking is also known to be goitrogenic because cigarette smoke does contain what are known as goitrogens, such as thiocyanates, and so smokers may be slightly more at risk of developing a goitre than non-smokers. Smoking may also worsen existing autoimmune thyroid disease, which is a fact that's often forgotten. So if you have someone who already has existing autoimmune thyroid disease, then if they are a smoker, they may be more likely to develop a goitre. The impact of foods has been discussed at length, and certain raw foods may be slightly goitrogenic, and I'm thinking of things like cruciferous vegetables, soybeans, for example. But the evidence is that the impact of diet is light if we're taking away the iodine side of things. Now, in general, the prevalence overall of a clinically palpable goitre in the population of an iodine-sufficient country, such as the UK, is 4% or so. Now, there are two main types of goitres, simple and colloid, and essentially their names do what they say on the tin. So a simple goitre means that nodules are absent, and the goitre has a diffuse, enlarged feel with no evidence of hyperthyroidism. And a simple goitre is often also called a non-toxic goitre. And most commonly, this is due to iodine deficiency worldwide. So globally, because of iodine deficiency, simple goitres are probably the most common type. The other type we may see is a colloid goitre, which is where we have uniform follicles present filled with colloid, and they can sometimes be distinguished by palpation, but not always. Now, as we all know, the typical presentation of a goitre is of a smooth mass in the neck, usually painless, but may cause discomfort due to its size. And there may also occasionally be symptoms of either an underactive or an overactive thyroid gland. Now, if you have a significantly large goitre, then there may be pressure symptoms on either the trachea or the esophagus, or occasionally both, and so you may get things like breathing problems, dysphagia, cough, or hoarseness. But in smaller goitres, these do not usually occur. If you have a nodular goitre, there may occasionally be a sudden increase in size and tenderness because of acute bleeding into a nodule in the goiter, although this is not common, but it is worth just being aware of that. Now, physically examining a goiter is limited in what we can find, even though the gland is easily palpable. And there's no question that the more experience we have at examining goiters, the more we may be able to get out of that clinical examination. So if you have someone and you find they have a goiter, then record the size of the goiter, the shape, and the consistency of the thyroid gland. And if you're able to feel any nodules, then try to record both the number and the consistency of the nodules that you're feeling and record those in the notes. However, one of the problems that we have in primary care is that someone's neck size can often impact on their examination. So a prominent normal gland in someone who has a long, thin neck may actually feel abnormal to us. But with a short, fat neck, an abnormal gland may be difficult to detect. There is a sign which I think is worth mentioning now, and I have to say, if you have seen this in practice, then you win a bonus point, because I've been looking for it all my life and I've yet to see a patient with it, but it does occur, and you may remember this from your medical student days, which is the Pemberton sign. And the Pemberton sign is a feeling of faintness along with facial congestion when the arms are raised above the head. And this occurs due to a substernal goiter that is then drawn into the thoracic inlet and then compresses the external jugular vein. So as I say, bonus point if you've seen that, but that is the Pemberton sign, and it is in all the literature about goiters. Now, what lab tests should we be doing in someone with a goiter? Well, in my view, anyone with a goiter should always have a compulsory TSH test to determine the current functional status of their thyroid. And obviously, if this is abnormal, then both the free T4 and T3 should also be checked. Now, because thyroid autoimmunity may often coexist with a goiter, I would suggest you also check for antibodies against thyroperoxidase and thyroglobulin. So that's the anti-TPO and the anti-TG antibodies. If you do find that your patient is hyperthyroid, then you can do a thyroid receptor antibody test, a TRAB, which can help to confirm whether Graves' disease is present or not. Now, what about imaging our patients with goiters? Well, ultrasound is absolutely key here, because this is not only useful for the diagnosis, but also as a baseline for monitoring thyroid volume over time, as well as checking the size of any nodules that may be present. And we should also be doing ultrasound scans on any patient with suspected or known thyroid nodules. If you find your patient has a subnormal TSH, then a radionuclide thyroid scan is usually indicated to determine the functional status of any nodules that are present, as well as helping to narrow down the underlying cause of any hyperthyroidism. It's important to say that CT scans are not a routine part of goiter or nodule investigations, but if you do have a goiter that's causing compressive symptoms, it can be very helpful indeed. Now, I have mentioned thyroid nodules a couple of times here, and I think it's worth just mentioning these almost in passing, because up to 7% or so of the general population have a palpable thyroid nodule. That's probably an underestimate. And almost 50% of adults have a thyroid nodule that is visible on ultrasound. And nodules can be due to growth and fusion of localized colloid-filled follicles or discrete adenomas or cysts. Now, I think it is worth mentioning thyroid nodules because thyroid cancer typically presents as a nodule, a really key point, and ultrasound is essential to determine if any nodules require fine needle aspiration cytology. So trying to simplify an investigation pathway in any patient with a thyroid nodule, always check the TSH, and that's your fundamental starter for 10. If that TSH is normal or raised, then do an ultrasound to assess the need for a fine needle aspiration. If this doesn't meet the criteria, then monitor, and if it does go to a fine needle aspiration, you'll get your answers. If the TSH is low, then go to ultrasound and a radioisotope scan. If that shows a cold nodule present, then you go along the normal criteria pathways. If a hot nodule is present, then consider treatments such as radioactive iodine ablation, thionomide medication, or surgery. Now, the criteria for which nodules to biopsy are important. So, biopsying, you should be looking at this with a high-risk history and more than a 5 millimeter size. So I'm thinking of something like a first-degree relative with thyroid cancer, a past history of radiotherapy or radiation exposure as a child. We should also be biopsying nodules if abnormal cervical lymph nodes are present, or if you've got more than 1 centimeter size of microcalcification and or a solid nodule. If you've got a mixed cystic or solid nodule greater than 1.5 to 2 centimeters, we should be looking at that, and we should also be looking at a spongiform nodule over 2 centimeters in size. However, if you have a purely cystic nodule, then fine needle aspiration is not indicated. So I think that was worth looking at just to remind ourselves about the pathways for thyroid nodules and why it can be important to look at them. Coming back to goitres, how we treat these obviously depends on the cause and the clinical findings and the clinical picture. And options here include simple wait and watch observation. If you have no worrying factors about a goiter and it's causing no particular problems, then observation and regular monitoring is fine. If you find that you do have a rare case of someone who has a goiter due to iodine deficiency, then iodine supplementation obviously can help. But avoid high-dose supplements here because that can trigger alterations in T4 levels. Thyroxine suppression is a treatment, as are the use of thionomides, things like carbimazole and propylthiouracil. You can ablate using radioactive iodine, I-131, but if you have patients who have troubling compressive symptoms or who fail to respond to medical treatment, then you may need to go into surgery to help remove some of that goiter. So things are the key points when we're looking at goiters. Just to sort of sum up here, we mustn't forget that goiter is common. Globally, iodine deficiency is the commonest cause, but not in the UK, where we're most commonly caused by thyroid nodules or autoimmune disease. The first test we should be doing to assess the thyroid functional status should always be the TSH, and thyroid ultrasound is essential because this helps to determine the need for fine needle aspiration biopsy if nodules are present. If you find that the patient with a goiter has a subnormal TSH, go to a radionuclide thyroid scan and seek specialist advice. But if you have a patient with a goiter who is euthyroid or the nodules are benign, then it is absolutely fine to simply observe clinically with a repeat ultrasound in 6, 12 or 18 months, depending on personal preferences. Treatment options include thionomides, radioactive iodine ablation and surgery. And as a final point, any atypical cytology or suspicious nodules should always be evaluated by a specialist. So that was a very quick run-through about goiter, but I do hope that helps the next time you see a patient in your surgery with one. And I do hope you found it helpful. Have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you consider following the podcast and leaving us a review on your favourite podcast platform. Do feel free to get in touch via social media at GPnotebook or email us support@GPnotebook.com if you've got any questions, comments or ideas for future podcasts. We really do love to hear from you. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups, which occur throughout the year, and also to download free shortcuts to help improve the lives of our patients in primary care. But until the next time, as always, thank you for listening and goodbye.